I think it's interesting to talk after David's talk earlier on about the situation in Scotland. And basically, we're not quite as far ahead as Scotland are, but they've been a great inspiration to us. And I think that David could probably sue us for plagiarism, the amount of information we've stolen from the Scots. But, you know, when somebody's produced a good model, I think it makes sense to use it. So you will see a little bit of crossover. So very much, and a serious thanks, because I think that we have communicated very well across borders, and we're learning very much from the experience there. So to give you some idea of what's been going on in Wales, in 2004 a strategy group was convened by the great and the good to design and look at how we were going to address the challenge of bloodborne viral hepatitis. Welsh Assembly Government just very kindly decided to fund a research programme. They thought, well, we actually need to find out what's going on before we start spending public money on this challenge. So we had a few years' research, which led to an action plan being drawn up, and that was submitted to WAG, and I'll give you a little bit of update later on about how far we've got with that. So basically our research, where you're going to see none of this, because it's all come up rather strangely, let's just see how far we go. Basically the research had a number of components. Probably the central part of the project was a very large prospective cohort study, which allowed us to determine hepatitis C incidence rather than prevalence. Now, incidence is the real holy grail of epidemiology. It allows us to have an idea of what sort of transmission is going on at the moment rather than what went on in the past. So we basically recruited about 1,000, 700 drug injectors from a wide range of settings across South Wales, followed up as many of them as we could for a year and retested them. This gave us some idea of the amount of transmission that was actually going on. And what we find in Wales, I don't know if I've got a pointer here, but the cluster of dots in the lower left-hand side of the picture are many of the larger Wales towns and mining communities down the valleys, Cardiff, Newport, Swansea, so on and so forth. And the dots up and to the right are samples from London and from Glasgow to compare. So basically we can see in Wales we've got a situation that's somewhat different to up here in Manchester and Glasgow and London, and we're in a much lower prevalence and incidence setting. Now, the take-home message for us, is that we stand to gain a lot by getting our prevention right in Wales. Now, I think if we go back and did this same study next year or the year after, I think we'll find ourselves inexorably moving up that prevalence incidence ladder, and I'm sure we'll be much closer to the prevalence and incidences we're seeing elsewhere. So it's not that we're doing things right in Wales. I think it's just a bit of a game of luck, and I think the epidemic has been slower to get going and slower seeded. Okay, so the key findings that we found, which none of those will come out, but hopefully I can remember some of them. The key findings were, first and foremost, that there was a huge burden of undiagnosed infection in Wales. About 3/4 of the drug injectors we recruited to the study who were positive did not know they were positive. So we're failing to actually identify infection. We also found that hepatitis B vaccination was woefully low, which was a real shock. Oh, thank you for my notes, that's very kind. My eyesight is sufficiently bad, I find it. Rather encouragingly, we found that for individuals who were on opiate substitution treatment, there was a lower incidence of hepatitis C. Now, this doesn't show causality, but it's a very encouraging association that led us to believe that one of the key pillars of what we're doing is to make sure we have high standard opiate substitution treatment in place. And if you're interested, some of this work has been published now. We also found that there was some real gaps in needle syringe exchange provision across the country. As you can imagine, we've got injecting going on in very small communities and in large cities, and the challenges of providing needle syringes vary greatly across the cities. In small villages, we have problems around anonymity. Maybe somebody's auntie works in the needle syringe exchange and so on and so forth. So there's particularly unique challenges to providing harm reduction in a rural setting that contrast slightly to the larger cities. What we then did is that we put these results together, and we gathered together a big conference in Cardiff a couple of years ago now, and we got the key stakeholders in the whole process, service user groups, drug agencies, health sector. We got everybody together, and we had a real sort of day of discussion to really work out what we were going to do. And lo and behold, the key strands that came out were very much similar to, as David has described earlier, which was basically improving diagnosis. So that was one of the first important keystones. We were failing to diagnose successfully. The second thing was to make sure we had services in place that would allow people to be treated for hepatitis C once they were diagnosed. Are we getting there?
It might get there.
I'll just burble on. We'll run out of time, honestly. Right. It's fine. We vaguely know what we're talking about. So basically, the group decided that the key things that needed to be improved were diagnosing people better, which we weren't doing very well, and actually getting better treatment services for hepatitis C in place across all of Wales, so that the areas that were treating successfully, that sort of model of good practice would run out right across the whole country. And we also highlighted the importance of really ramping up our harm reduction pillars of opioid substitution treatment and needle syringe exchanges right across the whole country. So having done that, we then put our sort of heads together and wrote up a consultation action plan that went out to public consultation, and that went out last year. And that action plan outlined what we felt needed to actually happen in Wales over the forthcoming four years. And the really key component was that we realised that we had to put some proper resources into improving treatment of hepatitis C in every area, improving prevention and improving diagnosis. So I'll start with the easy one first of all. Diagnosis, we're basically going to be relying on ramping up dry blood spot testing. Other colleagues have spoken about it so far, and we've piloted up in North West Wales, and we're very, very encouraged with the role that dry blood spot testing can play in improving diagnosis. And I really think that's going to be the key cornerstone for us in Wales. And when the funding comes through, that we hope will come through, not the distant future, that will be one of the first things that we'll really try to ramp up. The second thing is, if we're diagnosing people at the moment, the capacity of the treatment services for hepatitis C, the gastroenterology and hepatology services, the capacity is not there at the moment to treat all the people that we're going to be diagnosing. So in each trust in Wales, what we're arguing for is we need to have specialist nurses who can run nurse-led clinics and basically dramatically increase the testing capacity, but also to have specialist clinicians who are working at the interface between the gastroenterology departments and the drug services, because what we're realising is that successful treatment is basically getting secondary care and the drug services to be working together and community together and getting people through treatment. So that's probably going to be the two key components. The other component that's really quite important from our perspective is from the National Public Health Service is to try and improve surveillance, because unless we monitor and measure what's going on in terms of transmission, we can never really be too sure about how effective we are. So built into this whole process is going to be very much enhanced surveillance, so that when we test people and diagnose them, we know a little bit about their risk factors, and then we can find out a little bit about what's actually going on behind the scenes, which gives us some tools to monitor how we're actually progressing. So where are we now? Basically, the action plan has gone to the Minister of Health, and she had it, well, we sent it about 18 months ago. There's been a period of shall we say, quiescence, but we are actually expecting in the forthcoming spending round, which is due at the end of this month, a decision to be made. Now, we are very encouraged by the sort of sounds that are coming out, and we are really hoping that we'll get good news this year. We're sufficiently confident that we're actually starting to put in place the working groups, modelling much again what we're seeing in Scotland, a group that looks at diagnosis, a group that looks at treatment, groups at prevention. So we are on tenterhooks, we're optimistic, and I really hope in the next few weeks we'll have some good news, and I'm sure for those of you who are interested in Wales, if you keep an eye on the news, I'm sure it will get good coverage. So I'll stop there and hope that gives you some kind of overview. Thank you.